All right. I'm going to give it another 30 seconds or so to make sure that everybody who wanted to tune in tunes in. All right. With that, well, hello, everybody, and welcome. So excited to have you here. My name's Diane Buis. I'm here at MedTech Innovator, where I'm director of the US program. This is our MedTech Innovator Live number 4 of the 2022 seasons, our series of weekly webinars that we do as part of the Accelerator program. The Accelerator program runs for 4 months, and it's an opportunity for the 88 companies across of our 3 cohorts to learn from experts across all the ecosystem for MedTech. For those joining us on YouTube Live, on the live stream, MedTech Innovator is the largest accelerator of medical devices in the world, and it's a downstream accelerator. And what that means is we're not necessarily looking for people with ideas, but we are looking for people with companies that are up and running, that have teams and prototypes and early evidence that that technology works. And then we partner them with experts in the industry, strategics, and others to help them bring their product as quickly and efficiently to the market as possible with as much value as possible. And so MedTech Innovator has been doing this for the past decade. And the current US cohort has 54 companies, many of whom are on the call. And we're opening our webinars up to the broader ecosystem beyond this cohort. So for those on the live stream, feel free to put your questions in the chat. And for our cohort companies, please make use of the Q&A function that you have. And we'll try to get to all of those questions in the hour that we have on the live stream. And when we conclude the 1-hour live stream, speakers, if you can, we would love for you to stay on so that our companies can ask you a couple of questions live during the extra half an hour of private Q&A. That said, we fully understand not all 3 of our speakers can stay beyond the hour. So folks, if you have burning questions, I encourage you to ask them early. I will keep an eye on them and interject them into the conversation as appropriate. And without further ado, we are so thrilled to have 3 truly excellent panelists with us today. And rather than not doing them justice, I will ask them to introduce themselves. And I would like to first invite Sandra Elliott to tell us a little bit more about herself and the organization she works with. Welcome, Sandra.
Thank you. Thank you. I'm happy to be here, and a good afternoon, good morning, or whatever time zone you're in. Welcome. Super excited to be here today. So my role is the Vice President of Innovation and Health Ventures at Hackensack Meridian Health. And Hackensack Meridian Health is the largest network of health delivery services within the state of New Jersey. So we have 17 hospitals, tons of behavioral health, assisted living, home care, basically every point in the continuum you can ever imagine as part of the delivery of care. And we have those providers in the network. So it makes us a very interesting opportunity to really integrate with different types of technologies, and particularly innovative technologies based on where they can be best served, if you will, for meeting some of our needs. So not only do I drive internal innovation, but we look for organizations and like yourself who are early stage companies that are really trying to push the envelope on innovative treatments, innovative diagnostics, therapeutics, services, et cetera, and bring those into the organization in a structured manner that enables us to potentially kind of push the envelope on transforming how we deliver care. So we're super excited. I'm super excited to be here today to hear some of the expertise of some of the other panelists here on the call today, but also to hear some of the questions that you guys may have. Thank you.
Excellent. I appreciate that. And I would like to hand it over to Lisa Prasad at Henry Ford Health.
Thank you. Thanks, Diane. It's a pleasure to be here. And it's a pleasure to sort of share the virtual stage with Sandra and Emily. I'm well aware of their organizations, and they're doing great work around innovation. I am the Vice President and Chief Innovation Officer for Henry Ford Health. We are a integrated healthcare system based in Southeast Michigan. We have a wholly owned payer called the Health Alliance Plan with about 700,000 lives under management. And then we have 5 acute care hospitals and 200 care sites in the region. We like to say that if it's happening in healthcare, we are seeing it at Henry Ford. We provide everything from primary to tertiary and quaternary care, everything from pediatrics to geriatrics. We were founded by Henry Ford himself, and therefore we like to say that innovation is in our DNA. However, the formal Innovation Institute was formed around 10 years ago. And like my colleagues, we do the inside out innovation, commercializing technologies from the inside. We do mission-based work, but why I'm here today is because we do have a very robust program where we partner with early stage companies to bring new innovations into the system. So looking forward to hearing from the companies themselves and talking about some of our learnings as we've gone through the past 10 years of this.
That's excellent. Appreciate that. Emily Lafair-Frey at Geisinger.
Hi, everybody. I echo my colleagues on the phone here. I'm really looking forward to hearing their insights and am very familiar with what they do in their innovation institutes. Very similar structure at Geisinger. We are an integrated health system with $8 billion in revenue, fairly large for a central Pennsylvania market and Northeast Pennsylvania. And we really, combining, we have our health plan, we have a medical college, we have a research institute. We've had innovation for 35 years at Geisinger, really a couple different iterations. 4 years ago, we founded and started the Steele Institute for Health Innovation, and that's what I partnered with Karen Murphy, our Chief Innovation Officer, to really build up. I was employee number 2 after her, and my role is the Vice President of Innovation Operations. So similar to my colleagues, we have our health ventures, partnerships. We do things in the landscape of clinical redesign to automation to AI, and really leverage and partner with companies like yours to accelerate our mission and solve the problems of our time in healthcare. We're unique in that we have 600,000 lives managed on the health plan side, and with our ACOs and unique payment models, it allows us to innovate, I think, rapidly and invest in things in a unique structure. And so that's one of the things I really enjoy in working with Geisinger, is that different type of economic perspective that we have when partnering with companies. Really look forward to the conversation today, and thank you all.
Excellent. We're so happy you're here. And so perhaps, given that you're all in the healthcare innovation space and you're seeing the clinical needs for innovation every day, I am curious to hear, how does partnering work with each of your individual organizations? What are the business models? How does outside in innovation work? I know you all have inside innovation as well, but how does outside in innovation work for your organization? Maybe I'll start with Sandra, because I started with the introduction with Sandra, and then I'll go around.
Well, I love to say it depends, because a lot of it is where the organization is in their development cycle, kind of what their needs are. We specifically look to business models that are either co-development. Maybe they have the ability for us to take equity for effort. And sometimes, we look at, other types of relationships that may be a mix of both. But I think that, a lot of it depends on our interest level and the organization's needs to be able to really define that. But I think the critical factor for us is really about how big of an opportunity does that company present to us as it relates to potentially implementing their solution. Is it something that's that they're going to need additional assistance to develop? And really, we feel we can bring a lot of that to the table. So it's kind of a balance between where an organization is and what the needs are that we have and what we're comfortable with.
I'm curious to hear, Emily, your opinion or the Geisinger view of outside in innovation.
Yeah, I mean, Lisa was laughing and I was laughing on mute because I think it does depend, right?
Yeah.
you have to be solving a problem that healthcare systems are facing and clearly articulate it. So starting with the problem, and really we're speaking, I think a reminder to the folks on the phone, we're speaking from an innovation lens. So it doesn't mean that you can't partner with the organization in a more traditional format, but if you're speaking to us on the innovation side, I would echo Sandra, everything she mentioned from a non-traditional like equity relationship where we're giving more to the relationship than a traditional vendor. We make sure we're understanding the problem and building the requirements around that. And it may be influenced by an outreach from your company, or it's us seeking based on the problem we have. So that depends too, and how we get together as a relationship builder is some of them are precipitated through you guys and your engagement with the companies or at conferences. And then the other side of it is we have core things that year that we're looking to solve, and we go after and seek for individuals like yourself.
Lisa, how does that look at Henry Ford Health? Outside
Very
of
similar. Yeah, very similar. We like, so a couple of things that we don't do, right? We do not, at Henry Ford Health, we do not invest in companies. There are others who do that, we do not. We do not do free proof of concepts. There are others who do that, we do not. We don't buy for the system. If there's a early stage company that's done with its development and is purely looking for a customer, we're happy to make the introduction to the buyer, but we do not buy for the system. So what we do, like my colleague said, and in a very similar vein, we like to co-develop. We like to add intellectual property to the development of whatever this technology is. We like to, that can take anything from clinical trials to thinking about how the technology fits into the workflows of a large, complex provider environment, to thinking about payer models. So it's a variety of things, but the underlying theme is we like to add intellectual property to the product that's being worked on.
And I'm starting to see some questions come in, and I'll get to them, but I'd like to dig a little bit deeper on some of the things that you just said. Some of it is knowing the types of topics that you're looking for. Specifically, Emily, you mentioned there's 4 things we're looking for. Is that easy for a company to find? Is it a matter of going to your website? How do companies find out what the pressing problems are? Is it general healthcare problems? Is it problems specific to Geisinger? I'll turn it to the other 2 afterwards. How do we learn what you might be looking for at this moment in time?
Yeah, so I mean, we're a small group, so we have to be focused in what our problem and priorities are. So I will say the answer that's not going to make everyone happy is it changes because we're strategically planning and pivoting based on the landscape that we're challenged with. There are core problems that we are constantly working on. We've made a stance from the very beginning of our work at the Innovation Institute around chronic disease management and the way we use remote patient monitoring and unique care models with different care team members and using people to the top of their license. So that's been something that has been a core focus, and we've really stated, and Karen and myself have been on webinars and other things to talk about what our focus is. We don't necessarily have that because we don't want to restrict ourselves to say this is the only thing we work on, because you never know in the world of innovation. So it's not like we post the priorities really plainly for you through conversations and networking. I will say that if you ask me today, I have very clear guidance to myself of what we need to get done. But every 3 months we go through this cycle of making sure that we're working on the right things. So I can't post on the website because my marketing team would really be frustrated with my constant change. But I think that is important, just to get out there and have those conversations and listen. If you're interested in a specific organization to work with, and you specifically want to go down the innovation route, I'm sure I've heard Lisa speaking on webinars on her areas of priorities, as well as Sandra, and it's getting to know that organization and that Innovation Institute's priorities for that time when you are engaging them.
I'll ask the same question to you, Lisa. How do we find out what you're interested in?
Two ways, really. 2 to 3 times a year, we run challenges, and some of them are domestic, some of them are international. We run many of these challenges in Israel, but we identify a specific problem that we're working on at that point, and we do a marketing event and we launch the challenge, and when we encourage companies to apply their solutions. Our current challenge, which is going to launch shortly, is around technologies to support the bedside nurse. As we all know here on the webinar, the nursing crisis is huge and it's impacted all of us. And any interesting new technologies that we can rapidly implement within our environment is a win. So we do two or three of these a year. And then outside of that, we tend to be pretty opportunistic. There are people who send us their information, or who we reach out to in a variety of ways. What we will always do is try to find a clinical champion. And if we can find a clinical champion to work on this particular technology or this particular problem, then we will take on that project. So I would say, 25% of our work is based around specific challenges, and 75% of the projects are really opportunistic.
Yeah, and while, for example, we run challenges as well, when we started running challenges, you're going to find that every organization is always going to be looking for ways in which they can move the needle on U.S. News and World Report, CMS metrics of success. I mean, so those readmission reductions in hospital-acquired infections and those kinds of things, those are everybody problems, right? They're everybody challenges. And I think knowing what they are and then beginning to understand how they connect with the organization's strategic direction is really mission critical. And we base a lot of what we work on and areas of opportunity specifically on the strategic goals of the organization. So if I know that the organization is looking to reduce cost by 20%, and I'm just making up a number in a situation, then I'm going to look for organizations or run a challenge that's going to be focused in on those things that are going to be targeting efficiency, for example, and cost reduction. So I think it is kind of a push and pull. You're going to see some of it where we're pushing out. These are the things that we were interested in. And much like others, being opportunistic, but at the same time, looking for those organizations that are targeting those key strategic metrics that everyone is looking to improve. And it really translates into operational performance and clinical outcomes at the end of the day.
I really appreciate that. I think I'm looking at some of the questions that have come in, and I'd like to start picking one up by Rahim of Fluid Biomed, and that is really, at what stage do you engage with companies? At what stage should companies engage with you? What are the metrics? What is too early to reach out to you? And I'm happy to let any of you jump in. Lisa?
I can get us started on this, because this has actually been a very interesting journey for us over the past 10 years and an evolution of sorts. When we first started out, we would look at very, very early stage companies. We would look at, even concepts and companies that hadn't really gotten funding yet. We learned a couple of things. We learned that, one, the team wasn't sophisticated enough to engage with a complex institution such as ours. And two, we ended up working with a lot of what I would call hobbyists. So now where we like to engage is late seed round, Series A funding, sort of early stage enough where the product hasn't been completely developed yet, but late stage such that there is a product that somebody has already vetted at least once.
And maybe
later stage,
and you go ahead.
And later stage than that, of course, but probably not any earlier.
And perhaps I'll just stay with you for a second to ask, are there any particular milestones you're looking for? Like, you have a prototype. What type of milestones are relevant to you and your team? And then I'll let the other two jump in.
Yeah, it's fine if it's not FDA approved, but there should be a working prototype for sure that our clinicians can touch and feel, and something that can be tested in a clinical environment. We also like to see some funding. It could be friends and family round, or, again, seed funding from angel investors, but we do like to see a company that has some kind of a balance sheet.
Yeah, I agree. I think it's the same. I think for us, you can have a prototype, but if it does require regulatory approval, what we like to see is that you've got an identified path for that approval, and that how we fit, or how our organization and the work with our organization fits within that pathway. That we can either facilitate helping you get there, but it shows forethought, it shows leadership, and it shows that kind of going back to the comment of non-hobbyists, that this isn't just a hobby or a lifelong journey, which it can be a lifelong journey, but late seed, Series A is our sweet spot. That's where we don't mind convertible notes in late seed stage to convert in A, because we know you're potentially getting there, and a lot of companies are kind of faced with that at this point in time in the funding cycle, particularly given the marketplace right now. So. But prototypes are having something that can be tested and touched in field, if you will, like was mentioned by the clinicians or the people who would be using it, is really critically important to us.
Yeah, I mean, I'd echo everything Lisa and Sandra are saying. I think we take the same methodology. I will say there's a caveat to that in the 80-20 rule, right? That just like your investment profile as an individual, I think we have a small room for risk in our profile, and willing to take the jump in certain cases. And so that typically, though, is engaged by us in that we have a problem and enough intellectual property around a program we've developed where we seek a partner earlier stage in that to really co-develop and be a flagship of their work. But I will say, the amount of effort that it takes on our team is significant, and we do have to run it and make sure it doesn't impact our clinical operations and our health plan operations. So it's very thoughtful, and it's a robust process when we do it that way. So we only do maybe one or two. So far, we've only done one or two of those. Actually, we have only done one or two we've done two over the course of the 4 years I've been here. And they're running well and successful, but they take longer to see those realized benefits as well. So I don't think it's off the table if you're earlier stage, but most people, the door is harder to open in that respect.
And another thing that I believe, Lisa, you brought that up, a clinical champion. You've got to find someone who actually cares about this. How and when does that happen? Should a startup find a clinician in your system and try and talk to them first? Should they talk to you first? How do you identify a clinical champion?
They should talk to us.
Yeah, I'm with you. I'm totally with you. Talk to us first, because
just talk to us first.
Yeah, and we help find, the right clinical champions within the organization. Let me rephrase that. We find clinical champions in our organization that are respected both in the business mindset, but also in the clinical mindset, so that if they do like what you're bringing to the table, we know that they've got enough chutzpah, if you will, within the political landscape of the organization, that people respect that, yes, this is something that could have value that we need to take into consideration. And we're very strategic in the right people that we bring to the table for the different technologies, because we know what their expertises are. We know what they might be interested in, and really willing to help bring some clinical expertise to the table.
Yeah, 100% agree with Sandra on that. Come to us first. We know how to do this. When I'm looking for, how do you find a clinical champion? So when a early stage company, or when any company comes to us, we are not the subject matter experts in all of the clinical fields. All that expertise lives within what I call the mothership, right? Which is the broader Henry Ford Health. So I will we'll vet the company just to make sure that the company is bringing, something legitimately that could be useful to the system. And we'll go and I will identify a potential clinician, and they will respond to me in one of three ways. And this is what I've learned in 10 years. The one answer will be, you know what, Lisa, thanks. That's kind of cute, but doesn't really solve a problem I have. So not worth my while. The second one will be, good, it does solve a problem that I have, but you know what? I went to a conference in Boston last week and I saw 3 companies that did it better. So I'm gonna work with them instead. Or the third one, which is really what I'm looking for, is that they're gonna say to me, you know what, this solves a problem I have, and this is an innovative technology. So I am willing to invest some of my time to see how this can work. And once I get that answer, then I have my clinical champion. And then the innovations team will work with the champion and the company to put together the project scope and do all the business negotiations that have to be done in order for the partnership to take off.
Nothing better. They said it perfectly. Go through us. Don't find the clinical champion outside of that. We'll help do everything.
Great. What should be the goals of a pilot? Every startup is trying in one way or another to get into the clinic, right? So it's a pilot or a clinical study, and so the goals for a startup, of course, it's their way to get a foot in the door, ideally secure you as a client. But practically, what do you measure? Is it more clinical efficacy? Is it business model validation? Is it both? What are you measuring when you're designing a potential collaboration?
So I'll say we don't typically do as many clinical trials because we have a research arm, so we do forward them over that way. The only way we would be a part of like an FDA pivotal trial, as an example, is if the partnership is beyond that, in the relationship after the fact of the pivotal trial, which a lot of the times is predicated on if you get that FDA approval. So if you are coming for a clinical trial, we have a research arm that does that. And that's something you can look at from an organizational structure to know which is the right place to go. If we get a request from you and it's not in our lane, we'll certainly route you. So don't worry about that. I would say with pilots, we do a pilot. And I say that because if it is something that what we will think about is the requirements and be creative in how your solution, oftentimes your solution may require integration. And when it requires integration at the level of a pilot, knowing we talked about the nurses constraints we have right now in our organizations, there's also a constraint in resourcing on the infrastructure side of things, and contractors that we use costs a lot of money. So when you incorporate a pilot, that increases your cost to the organization. So we have to be thoughtful on that. So when you're presenting your idea, talking about Epic integration or Cerner integration, EMR in general, is really important, but also thinking about how can you uniquely, if possible, test it out without that to achieve X, Y, and Z. And then once you get it integrated, it only exceeds the expectations of what you achieved in that pilot. I've had to try to think about how we get creative in that to be able to do pilots rapidly, which is what I want to do in innovation, is innovate rapidly with you. So how can we do things that are in a non-integrated setting with a path to integration? So that's one of the key factors, I'd say, in which makes a partnership successful, is having that joint thought process and willing to be able to think about the non-traditional implementations, even though your product is best suited once it's implemented and integrated within our other native technologies.
Yeah, I fully agree with that as well. I think it is a huge challenge that everybody is, the first thing that comes out of our clinical experts' mouth is this, have you integrated with Epic, for example? It's just logical because their workflow is really based a lot on this systems. I think, one of the golden rules that we use is the crawl, walk, run method, which is, going back to what Emily was saying, is really making sure there's a scope that has building blocks to success. How do you break out if it's readmission reduction? You know, what are those critical factors that your product leads to, or your solution leads to, that can be measured in a way that builds to the next level? And I think that's a critical component for us. But it's gotta be able to have a metric that can be measured, and it has to be a hard measurement. It can't be a soft measurement. This is going to save XYZ nursing time. Well, if it's going to save XYZ nursing time, where am I getting that from? How do I know that if I implement this, my nursing costs are going to go down? You've got to be able to really define a very specific metric as well that can be monitored and measured throughout the pilot process.
Yeah, and I agree 100% with what was just said by Emily and Sandra. If I had to summarize, I would say that the value proposition really needs to be very clear from the beginning. How is this going to add value to our system? Will we end up spending more overall by implementing this technology than we're spending now? And if the answer is yes, then that may be okay if the value is there, if we're going to save 10% more lives, as an example. So it's all about what is the value proposition and what is the plan that's there to reaching that value proposition.
I want to make a quick comment. We've been getting a number of questions, and where do we find either contact information or on the website, the types of things that you're looking for? We'll follow up with a cohort on some of those things. So want to make sure that you know that. But with that, I want to go into a little bit of the economics as we're talking about pilots and trials. Wayne asked a very specific question that I want to broaden a little bit more. Actually, no, it wasn't Wayne. My apologies. The question was whether champions get equity, but I want to broaden that to the economics of trials. How does collaboration work? Collaboration on intellectual property. Do you take equity in companies? Do you pay for initial trials or pilots? Do you expect to be paid? What are the different dimensions of the economics of a pilot with your organization?
Who wants to say it depends?
I was going to say that.
It depends for all three of you. Go ahead, Emily.
I know, I was going to say somebody's going to say it. So. Yeah, it really is. It depends on the size of your company. It depends on the size of the profile of the project, and what the give and the get is so important, right? To how the compensation works. So what are you giving to the organization with your product, and what are we giving related to the sweat equity in whatever form, or the intellectual property in whatever form that comes. So I would say that is for the Innovation Institute and how we take it by use case. There's not a specific formula to how we derive the value within each partnership. Related to the champions, we do have a very specific process and policy for our clinical champions, and revenue share and equity and conflict of interest is a consideration for people. So that's why it's better to go through the Innovation Institute first, outside of finding your own clinical champions, because then sometimes there arises a conflict of interest if you're engaged with somebody in a non-traditional format that works at our organizations and then they bring it. So I think that's a consideration in why coming through us to identify those clinical champions, if you do want it to be something that this organization, one of our organizations, look at, is being considerate of the policies we may have on conflict of interest.
So for Henry Ford Health, we typically will not do free pilots. We do expect there to be at least a cost sharing between the company and Henry Ford, depending on what the project is. We are very concerned about fair market value. So we need to make sure that no matter what the project is that we do, we get fair market value in return for the contribution that we're putting in, because we can lose our not-for-profit status by not being mindful of that. We cannot be using federal and other private resources for the inurement of a for-profit corporation. So we need to make sure that fair market value is returned. That could be in the form of equity. It could also be in the form of a royalty agreement. And we actually end up doing a lot more license agreements with long-term royalty than we do with equity. That actually works fine for us. And we have no issues with giving long-term exclusive rights to the company for whatever it is that we've co-developed. In terms of compensation back to our clinical champions, we do have a methodology for rewarding our champions who have made significant contribution to projects. And that's done on a case-by-case basis. And that is all part of an employment policy, but there is a mechanism for that.
And I echo everything that's already been said. I think it's a complex situation, best managed by us, because otherwise it gets very, very messy, very, very fast.
Yeah.
Understood. Staying on the topic of economics, how much does reimbursement matter? What if a company has not fully fleshed out their reimbursement strategy? Maybe they don't have CPT codes yet. How do you look at that?
Well, I think
that's one.
Go ahead.
No, go ahead, Sandra, please.
I was just going to say, I think a couple of things come to mind. One is something that's going to be operationally enhance our ability to perform at a higher performance level. In other words, is this an operations oriented thing, or is this something that's a service, a clinical treatment or a diagnostic that may require a CPT code? The hardest area is remote monitoring, right? So for us, we have a tendency to get more focused, become much more focused in on what is the outcome of that remote monitoring. Is it going to enable us to get patients out of the hospital faster and increase our capacity and do it with a high level of clinical confidence? Is it going to enable our home care agency to be able to meet patient expectations and needs better? So I think there are a lot of different ways for us to look at it. I don't necessarily, I'm not 100% driven by whether or not there's a revenue code or a CPT code based on the technology. I think a lot of that depends on what it is you're bringing to the table.
Yeah, I would agree with that as well. We're not 100% driven by the CPT coding. In fact, we believe that that's part of our contribution, or that can be part of our contribution, is to create the case for getting that CPT code in the first place. And we have a pair that partners with us to evaluate the technologies.
Yeah, I would echo that. I think it's a part of our contribution, and there are a lot of cases where something is not even in the domain of billable that we partner with, and there's an argument whether it's through reduction in utilization or another factor which really drives the business model to what they do. The point I do think it's interesting for those of you that have products with billable services, or if you don't, but we believe it should. Like, I've seen unique companies lately in the domains of upcoming technology like AI. I've been working with companies that really advocate on, Capitol Hill for those, like the new CPT code for AI screening. If it is FDA approved, you can use that AI screening code, and we can be an advocate and help you. There are cases where it's just better access to care, especially in a rural landscape for us. And so looking at and being creative, innovative on both sides of the spectrum, us or you, and seeing if it's not billable today, is it a service that could be billable? Because I've seen some really cool companies push the landscape to make things billable that should be. and continuing to actively pursue, our RPM, our telehealth, our CCM, those type of things are important to think about the future of healthcare. And so if you're an advocate to push for that, that's certainly an incentive for us to work with you.
One of the things that you can tell I'm circling around the topic of pilots because so many of our companies are really thinking deeply about those, and the data. So you have to get all the data you possibly can out of a pilot because you can't go back. How should data be collected? When and how do you bring your IRB in? How is the data then used potentially for regulatory filings? Who gets involved in that, and how does that work?
Oh, this is a really messy area.
That's why we want to hear from you. It's really tricky, and it is tricky to navigate for the startups.
If it's de-identified data, it's a little bit easier. If it's not de-identified data, then it really does have to go through IRB, and there's a whole separate approval process, approval and oversight process that needs to be followed. And we all have our own IRB offices, and that's just something that we can't not do because the data isn't mine. The data isn't the health systems. The data is the patient's, and we need to respect that it's the patient's data, and we need to treat it in a way that really protects it. Having said that, we totally understand that a lot of these technologies are not going to get developed without a whole lot of data. So we have a team between innovations and our legal office and IT that looks at these things from both perspectives. One, can we deliver the data? And two, should we deliver the data? And again, these decisions get made on a case-by-case basis, and we really do look in depth at every single case.
Agreed. Same here.
I think IRB, though, I'd say no matter what pilot, even if we're confident that it's not going to go, we put it through that review just to get that sheet of approval because they have their process. So we just want to triple check on that, make sure that it's approved. So we do go through that pretty regularly. And then we have a data ethics committee, which is a whole separate host, like Lisa said, with our information security, our data, our informatics officer, and our legal team to really take it on a case-by-case basis.
I might perhaps just double down on some of the requirements. How much importance do you attach to some types of certifications? As you just mentioned, Emily, the data. And as I'm preparing for more of these panels, I'm working on one that is on data privacy and security. So I might just as well ask you the question, how fleshed out do the processes for companies have to be for you to engage? How do you, what are the connections inside of your health systems that you make before making a decision to go into a pilot? Or what do you need to see from a startup to be ready to say, yes, you're good to go, we can bring you on board?
Yeah, I'm sure we all have similar processes. We use we call it our Coral review. I'm not they do a lot of things that I'm not a subject matter expert in to speak to what they look at, but the hood of your security processes. There are certain certifications depending on the situation of what the product is doing that they have to have related to the data sensitivity and what we're sharing. They have to have some cybersecurity related layers to protect that. And even if I just would stress, there's a risk to us if you don't have those layers, regardless of whether you're willing to take the risk, financially associated contractually, it doesn't matter. We uphold our patients and member data to the highest level of security. So even if you're willing to contractually take that risk with us, we wouldn't be willing to take that risk with you unless you have those appropriately technical architecture layers to do that. But I'll say I can't speak to, and I don't know, Lisa or Sandra, if you can, the actual requirements or certifications you have to have.
I think I would say the same thing. And I think one of the things that's crystal clear from our perspective, and having gone through this, data security and hacking is a huge issue. And we're not willing to take the risk of data being shared in any way, shape, or form, that even though maybe within our network we can protect it, we can't protect it in yours. So I think it is a ongoing threat that we face. And so the standards are pretty high on the security of the data.
Yeah, 100% agree. You know, we're agreeing on a lot, and I think that this just really speaks to how much healthcare really shares the problems across the board. So
Right.
if I was to look at the bright side of that, the bright side is that if you create something that makes life better for one of us, chances are that all three of us will buy that product. So that's the opportunity. But yeah, we have something called the IPSO review, which is a security office that has to review the company. Then you have to get a business affiliate agreement, which, you know, certifies that you have the right controls in place to protect the data. And those things have to happen before we even go and make a decision on should we give it to you. It's just a matter of, those are like, can we give it to you? So
I think kind of going back on one of the things that Lisa brought up is the scalability across multiple potential clients, if you will. I think one of the things that I would kind of circle back on the pilot side of things, you've got to be able to bring some implementation support for that pilot to the table. We can't do all that heavy lifting. And so what that means is you've got to have thought through the scalability of that pilot. And sometimes we can help you with that. But I think in order to be successful in doing multiple pilots, one at one location and potentially beginning to evolve it into other locations, you've got to think about ease of scaling a pilot, because it becomes way too labor intensive for us to take on that. It's not like, okay, give me your technology and we'll pilot it. We need, you know, a certain level of implementation support to be able to do that.
And I'd say that back to your question earlier, and kind of why we probably all answered Series A, you know, the preference in you've done it with a client before, you typically have figured out some of those kinks after you've gone through a couple of the partners. And so that's why we also tend to balance our profile of partnership structures, because the amount of work and intensity in helping you build those BAAs that make sense and understanding what it takes to go through some of those information security processes, that's a lot of work on our end with you when you're really early stage. And sometimes we're willing to invest in that with you. And sometimes we have to make choices in where our priorities lie and how we can balance that. So I think that's why we tend to lean on those that have validated those processes and can bring that experience to the table.
One of the questions that just came in from our audience is the timeline. What should companies expect from the time they approach you, especially when we're looking for a clinical study or a trial? What timelines to expect? Many health systems just tend to say, be patient with us. We get a lot of these requests. And so what is a reasonable timeline from proposal to actual enrollment?
Oh, I can't wait to hear the answer to this from my colleagues.
Yeah, I'll take a stab if you guys are okay. So I think it depends on the way. So like I think when you're building out your business plan of looking over the next 18 months for your board and you're projecting, I think there's a balance, and it really depends on your product too, I'll say, is a balance of when we have a problem and we need to solve it, we can move pretty quickly, but that's a balance of our priorities, right? And so when we reach out, those are the opportunities where you may be able to grab that business and move quicker with us, as long as you can keep up with that pace. But I will say on the flip side, if you're coming to us looking at the capture of the sale and putting it into your books, it probably would be more like coming to us and saying you can do something in 3 months. It is, we know that's not going to happen for us, especially with our legal processes. We just talked about information security and the other areas. So definitely book it out 12 months to 18 months. I just to be realistic. And that's the point of signing. I'd say, I hate to say that, sometimes that means the point of signing. But it's a dependency. I mean, it depends. Once again, it depends on if we are coming to you with the problem and we're doing that landscape and we need to solve for it within this year, we may be able to move quicker.
I would agree. I think it's a 9 to 12 month process for the most part, and that's assuming that we feel like this is something that we can move on. Because I think a lot of it depends on how much of a building block and the complexity of your solution. I think, again, thinking back to a pilots and stages can be done much faster than, soup to nuts. So I think, thinking, strategically about that is kind of a critical thing. But I think 9 to 12 months is a pretty aggressive timeline, and it's always going to take longer than you think. And it's going to take longer than we think usually. It's just tough because there are a lot of things that, while COVID was going on, yes, we had the COVID challenge of just it just wasn't the focus, right? Of a lot of organizations to bring in a lot of new technologies. Having said that, now we're backed up and we're trying to get a lot of things done to catch up for that lost time. So you've got a queue that's increased in its size, and the structure that is going through is pretty much going to remain the same. So it's a lot more. There are a lot more demands on a lot of the people in the organization. So it's just going to take longer.
Agreed. We're looking at the earliest 6 months, and for the more complex projects where you might need clinical input as well as data, we're probably looking at 12 to 18 months to get something launched.
I don't know if you guys have experienced this too. I feel like we put a lot of stuff on hold during COVID, and that's something just to consider. It's a now problem. It may not be a problem in the future, but at least right now, over the next year, we are catching up with some of those organizational things that we planned pre-COVID. And so that puts a backlog and constraint on our infrastructure team.
Absolutely.
We have, for us in the innovations side, we have some backlog, but not that much. Our larger issue is that due to the staffing shortages and just the COVID that doesn't go away, we have so many different challenges, operational challenges, hitting our IT team, as well as our clinical team, as well as our nursing team. So, and all of those challenges are taking priority over new pilots. Mm-hmm. And therefore it's difficult right now to get bandwidth from key people around the system to do some of these projects. Hopefully that'll slow down.
So I think, just to be clear, for my organization, probably the same for Sandra, we've articulated it better than I. That's really the backlog. It's not the team. It's our partners that we're trying to balance the innovation speed versus the organizational needs.
Absolutely, totally agree.
And so out of the, at least in the US cohort, half of the companies are accelerator companies, the other half are showcase companies. They're raising usually a Series B. Many of them are already in market, say in other countries. And so when a product is approved and a company just wants to partner to collect and publish data, that's a different type of pilot. And so is that, what does that look like? How is that in terms of timeline, and how is that in terms of approach? Same approach, go through innovations, don't just find a clinician. I'd like to hear your view on a slightly later stage company, potentially with product in market in the US or with product in market elsewhere.
I can speak to that. if this company comes to innovations, we will do our best to connect them with whoever the right buyer might be. As you probably know, and all the companies know, it's not easy to find the decision maker around buying things at health systems. Do you go to supply chain? Do you go to the department head? Do you go to the nursing floor? Who is actually going to say yes to your product? So we will do our best to connect the company with whoever that buyer is, and then just get out of the way, because that's not something that innovations will have any role in. So yeah, we help companies like that by making the right connections.
I agree with that. I think the only difference is, particularly if you're at a Series B, then the question becomes, if we're piloting it, the question is going to be who's going to gain more value out of this. And in those situations, we may not want to pay for the pilot. You may end up paying for that pilot, depending on what you're trying to accomplish. So I think that's a critical issue. And technology coming in from other locations, if our clinician, other non-domestic for us locations, a lot of it depends on the value that our clinicians feel it brings to the table, and how we can potentially help build that building block of approvals that you may need from a U.S. perspective. So again, I hate to say it, but a lot of it depends. But in that scenario, we're expecting that there's a lot of effort that's already been put in place by this organization, and it should be closer to a buy decision, if you will, instead of an approval decision. A need to get approval within the U.S., for example.
Yeah, I would echo Lisa and Sandra. I think our process is really similar. The only thing I'd say is when you are reaching out, a consideration for those non-US companies is making sure you're pivoting, and most of you are probably doing, I'm stating the obvious, but pivoting that value proposition to meet and make sense to the healthcare landscape in the US with our federal and regulatory and payment structures, making sure you do adopt that for any presentations or pitches with that methodology.
We're coming up on top of the hour. When we end our YouTube live, I want to give each of you a chance to give a piece of advice to any of the innovators who are listening, or share an anecdote of things that went well or things that went terribly with a recent pilot. So advice, things that went well or things that went terribly. I will start with Emily.
Oh boy. Advice for companies. Be clear and concise on what your value. I think we've said this. I'm just going to reiterate something to reinforce. It's the clear and concise communication of your value proposition and your business model. The easier you can make it for us to figure it out, the better it is. So be a partner in the process of understanding how we can work together. And I would say, you said, so advice, and then what was the good and the bad?
The good and the bad. That said, you get to pick either, but if you're willing to share a good or a bad, that's great. You also get to say, I've given advice. Let's see if Sandra or Lisa have a good or a bad.
Well, I'm an internal optimist, so I'll go with the good. But I mean, I'll just say that I think the best partnerships are the one where, especially in the innovation landscape, to remember we're truly looking for co-development opportunities and something that's unique and has more depth than a traditional vendor relationship. And so the best ones have the structure that provide a feedback loop for communication consistently. We dedicate a lot of time to it, and so making sure the infrastructure is there, and you recognize that time, whether it's meeting on a bi-weekly basis from different levels of the innovation group at the product level, and then at a leadership level like ours, just to check in to make sure we're trending. So 6 months down the road of the relationship, we're not shocked together that something's going wrong. So I just say that's the good. I've had really great partners through the 4 years that we've worked with that just are such good communicators and highlight things at the point, and we work together to solve them. We're not trying to point blame. It's how can we solve them together? So.
Excellent. Lisa, would you like to go next?
Sure. I'll just give, in the interest of time, two pieces of advice. One is, no matter what it is that you're trying to develop, keep in mind how they fit into the workflows of our provider environment. How will it change the way that we currently perform tasks? We are incredibly regulated. We have very specific training programs for our nurses, for everybody who works that touches a patient. They're trained in a specific way. Just be mindful of how your technology will change the way in which work changes, because all of that will require training and retraining. The second is, be mindful of the financial situation that we are under. So we are moving toward a value-based world, but we're still kind of in that volume-based world. And we are working at margins, in a good year, 2%. In years like this, we're at a negative margin right now, as many health systems are across the country. So when you come to us and say, because of my technology, you're going to save 30%, and let's share that with you. I'll take half, you take half. Well, those theoretical savings can't really turn into cash flow for you as a partner. So just be mindful of our operating environment before you solidify your own business model, if you will.
And I would echo kind of the going theme here is partnership. I think you have to see organizations as being really good collaborators. One of the things that's very interesting is when you get the right clinician, whether that be the bedside nurse, the physical therapist, or a physician, really engaged, they're problem solvers by nature. They want to solve problems for their patients. They want to take care of their patients. And when they get invested, the magnitude of information that you learn and understand how your product or solution fits in is dramatically different than maybe in many situations you think your product or solution will work, and they may open opportunities that you never thought of. And I think so being flexible enough to, as a collaborator with organizations, is one of the best pieces of advice that I can give, because you're going to gain a lot from it, a lot that you can't quantify, but it will follow up and translate into a product or a solution that's easier to sell, easier to implement, or meets a need even better. So I think that's the biggest thing, is really understand you're going into a relationship, and going back to communication, et cetera. It is about a relationship when we start working with you. And that's one of the crystal things, the things that we try to crystallize is this someone that we can develop a relationship with from a partnership or collaboration. And if we can't, because the founder is too hard-headed or focused in on this is the only way we're going to do this, there's a strong likelihood that we're not going to work with you. So I think it's just important to understand that there has to be a good mesh of culture and organization, and you're going to waste your time if you're not paying attention to that as well.
With that, I would like to thank our three panelists and conclude the YouTube Live. Folks out on YouTube, come back next week. We're going to talk to payers. But I encourage our panelists to stay on, and I encourage the cohort to stay on for the continuation of Q&A that is